So today we're going to be talking about HRT and the myths surrounding it, and there are many, aren't there?
Yes.
And I think if we can get a few of the messages over to people today about how safe generally HRT is, and how much it can help women, that would be great. We've got quite a lot of questions, so perhaps I'll perhaps start off with some questions. Do you think that sounds a good way to start? So first of all, Sarah, what is HRT? Who needs what, and what about periods? Is one question.
Okay, so HRT is essentially two hormones for most women. So it's estrogen, which is the hormone that we miss the most and has the most sort of help with our symptoms, but also the most protection for our bodies. So all women need estrogen replacement, and if you still have your womb, then you also need some progesterone. So that's sort of the safety bit of HRT, if you will. So for most women, combined HRT, which is both, will give them an awful lot of benefits, making them feel better now and also protecting their future health. And for some women, it's also appropriate to add in testosterone if they need that, although that's not currently available.
We've lost, isn't it? As the ovary fails
Yes.
as part of the menopause. So it's simply replacing. It's 3 words, 3 letters, isn't it? Hormone replacement therapy. We're just replacing what we've lost.
Yeah, exactly. Yes.
So estrogen and testosterone, perhaps, and we use the progesterone to protect the womb if you have a womb.
And then if you're in the perimenopause, so you're still having periods when you start it, then you have the type of HRT that we call cyclical. So you have the estrogen all the time and the progesterone just part of every month to actually induce a period, so it carries on your cycle. And if you're beyond the menopause, you sort of graduate through to what we call continuous HRT, where you have both hormones in equal quantity both days.
So just to pick up on what you said, actually, the perimenopause, so when you're having periods, you can have HRT. I think that's a common myth, isn't it?
That's a really common myth.
Yeah.
So many women come and say, I wasn't allowed HRT because I hadn't gone a year without a period. Yeah. And that's wrong.
That's
we know
crazy.
The earlier you start your HRT, the more the benefits.
As soon as the body's sort of suffering with fluctuations of estrogen levels, which it will do, that's called the perimenopause, isn't it? It's actually suffering with symptoms. It's good to start estrogen replacement then, because that sort of evens out the levels of estrogen, doesn't it?
So the perimenopause is a bit like being on a roller coaster of hormones. You have highs and lows, and it's scary. Yeah. And if you give HRT, although you create a cycle, it's a lot. The highs are less than the lows, more importantly, are less. So you have a much nicer journey.
Yeah. And so sometimes people worry about starting HRT. Well, you've got to go through the menopause anyway. Does it simply delay that dreaded day of the menopause?
No.
That's a nice, quick, simple
answer. It doesn't.
Lovely.
I think looking back historically, I think a lot of that myth came out of the time after what's called the WHI study. So where a lot of women either, because of the scare stories that came out of that study, a lot of women either threw it away or had it taken away from them by doctors.
Yes.
So you had lots of women who were still clearly symptomatic, but because they had their HRT taken away, almost overnight sometimes, the myth grew up that actually if you start HRT and then you stop it, you're still going to be having symptoms. And of course the truth is that you're only going to be having symptoms if you would have been symptomatic anyway.
Yes. Yeah.
And I think that's it's huge. I don't know how much you see it, but I hear it all the time.
We hear it all the time, actually. Well, don't bother with HRT. You've got to go through it at some point, so you may as well do it now. Because if you stop it, unless you want to be on it all your life, which I would advocate for many people, actually, anyway, but it doesn't delay the dreaded day, does it? And the average time length of the menopause is difficult to say, isn't it?
There's sort of, you kind of hear, don't you, it's between 4 and 8 years, it's 7 years, etc.
Yeah.
I think you said earlier, Rebecca, we just need more studies, really, don't we?
I don't think we know quite often, actually. I think it's quite poor research, wouldn't you agree, of how long it's lasting? But yes, they usually say the average is 7 years. But Sarah and I and you, we've all met. I've got patients. I remember when I first started doing general practice, a 90-year-old lady came and said, I'm still having my flushes from my menopause. And I was aghast. I thought, that's not possible, surely. And then, of course, I saw more and more. Do you see that?
Yeah,
so,
absolutely, yeah.
So symptoms can go on forever, can't they? In
Exactly.
Some women. So so that is a key thing. HRT does not delay the menopause. And is it worth a woman coming off HRT to see if she has any symptoms? If she's feeling good on HRT?
It's HRT has got the two main benefits. There's the symptomatic control.
Yep.
So actually, if let's say your natural menopausal symptoms were going to last you 4 years and you've stayed on HRT for 5 years and then you come off it, actually you'll go, oh, great. I'm done. I have no more symptoms, and that's okay. That's that's a woman's choice. But she's then no longer getting the other protection from HRT, which is looking after her bones and her blood vessels. So it just involves an informed discussion with that patient. Say, what are you getting out of this, and what are your priorities, and what would you like to do? But we know NICE guidelines are very clear. There's no maximum duration for taking HRT, and it's absolutely fine to carry it on as long as you would like to, and for some women, lifelong.
And it's important, isn't it, that those women who stay on it for a long period of time, they have an annual consultation with their GP or their specialist, whoever they're seeing.
To discuss the pros and perhaps the cons and maybe some risks that they need to be aware of, but the huge benefits as well.
Absolutely.
Because there's a mantra going out, another myth saying that you can only have it for 5 years, the lowest dose for 5 years.
Yeah. And again, that's really old news, isn't it?
It's really wrong.
And I think, again, that came about, didn't it, because we know that there is a very small increase in the risk of being diagnosed with breast cancer if you've taken combined HRT for more than 5 years. And I think that's where that myth
that
came about.
Yes.
But it doesn't mean that beyond 5 years, the benefits of HRT still outweighs the risks.
Yeah, that's right.
And therefore, that 5-year thing has got to go. And also another thing about once you get to 60, you should come off HRT.
Yeah.
That's another that has come out of nowhere.
Yes.
And there is no age at which you have to stop.
Yeah.
No, if you want to continue and you've had a discussion, that's up to the individual, isn't it? So what are the health benefits of HRT? Well, I think we briefly touched on that, didn't we, earlier, about the heart.
I mean, obviously symptoms, but longer term health benefits, well documented, are bone health and heart health.
Yes.
But we're learning so much more, almost on a monthly basis now, about the protective benefits of HRT, of estrogen for the brain. And I think that's only going to continue. We're only going to learn more and more. Exactly. But everything that we're learning at the moment is looking very positive.
Reduction in bowel cancer as well.
Yeah, absolutely.
And it's also, we think it now reduces the incidence of diabetes, or for those women that have diabetes, actually it often controls their sugars better.
Yeah,
And
absolutely.
dramatically, it reduces the risk of death.
Yes,
women on HRT live longer than women not on
Absolutely.
HRT. I mean, that's a huge end point, isn't
Absolutely.
That's plain to see. You will live longer on HRT. Overall, the studies have shown than if you don't take HRT. So what about people with a family history of breast cancer?
It's always a tricky one, isn't it? Because so many women are told, well, you have a family history, you can't have it. And actually that's not correct, because I'm sure you've both seen plenty of women who have that history. And as with any of these consultations, it has to be individualised, doesn't it?
Of course.
And eventually, the final decision really should be down to the patient.
Yeah.
It should be about informed choice.
Isn't it?
Absolutely.
As ever, we always come back to that, don't we? It's about sharing decision, shared decision making,
Absolutely.
guiding people through, giving them evidence, and then deciding. But actually, most people, when they think they've got a family history, it's not a significant family history. Isn't that right,
No.
Sarah? You've seen people in the
I think we have this, and a lot of women that have another female in the family with breast cancer almost presume that it's inevitable that they will get breast cancer, and actually that is simply not the case.
No.
Having a family history does alter your own risk slightly, but it doesn't make as big a difference as most people would think.
1 in 7 of us are going to get breast cancer.
Yeah.
So clearly, if you have
And
a
that's
family
the
with a few
national
females in
population.
it, several of the females in your family may have. It doesn't make it may have breast cancer, but may not be a significant amount.
So it's very important to get a correct history from those ladies. So we want to know which relatives, how many relatives are we talking about? Actually, if there's a male relative with breast cancer, actually that's quite significant. So we need to know actually who is it that's got it. Do you know what age they were diagnosed with it? And go through. So actually, a few women actually need to go and see the genetics team to actually see have they actually got an inherited gene in the family that makes them more susceptible. But actually, that sort of cancer accounts for less than 5% of breast cancer in this country, and actually most breast cancer happens spontaneously, or is much more likely to do with lifestyle issues such as being overweight, not exercising, drinking alcohol, smoking. And actually those things we've got to talk about and not keep concentrating on family history.
Absolutely.
And what about the risk of HRT? People, the main thing I find in the clinic, people are worried about HRT not starting it is because of the risk of breast cancer, their perceived understanding of the risk of breast cancer. So perhaps we could say a bit about that.
I think, again, sort of right back to that, sort of roundly discredited WHI study now, a lot of people still remember those headlines because there were a lot of them and they were scary. And I think a lot of people are not remotely aware. I mean, I know a lot of clinicians are not aware of body identical progesterone. And I think a lot of people still think estrogen breast cancer when actually we're really talking more about the synthetic progestogens than we are about estrogen at all. So I think it's unclear messages both for women and also for doctors. And so you just have these really muddy waters. And if women can't get factual, evidence-based information, then they can't make those informed choices.
No, exactly. So just to be clear, the risk of breast cancer is very small on combined HRT. That means estrogen and progesterone. Overall, looking at all the types of HRT with the older synthetic progestogens, there may be a very small increased risk, but that tiny increased risk is much less than, say, other lifestyle factors, such as drinking 2 glasses of wine, which is a higher risk than that type of HRT, or being overweight or obese is up to 10 times, 6 to 10 times the risk of HRT per se, of developing breast cancer. Yet I see a lot of ladies who are happily drinking 2 or 3 glasses of wine every night, and they're probably overweight and they're not exercising. So their risk actually of breast cancer is really quite significant from that. Yet they wouldn't touch HRT, which is a lower risk than all those lifestyle things I've just mentioned. And actually the secondary effects of HRT, when people are feeling better, they're perhaps not drinking alcohol to numb their symptoms, they've got more energy to run around and lose weight and get into an exercise regime. So in the end, they actually decrease their risk of breast cancer.
And also for those women who've had their womb removed, who are on estrogen only, it's actually a reduced risk.
Exactly. There's no increase. So it's nothing to do with estrogen. You always think estrogen in your boobs, don't you? But it's nothing to do with estrogen. No. It's the progesterone possibly, and certain types of progesterone could increase the risk. Absolutely. So estrogen only HRT does not increase the risk of breast cancer, and likewise the younger menopause sufferers, there's no increased risk of any problems for women under the age of 45, and they should have hormones till they're 50. Otherwise they're going to have health risks in the future. No, it's important to get that over, because that's just so stuck in the minds, isn't it? If people don't think. The other thing I see a lot of things, people have had are worried about blood clots and with HRT, they've heard about that.
We do know that there is a small risk of a blood clot if you take estrogen in tablet form, because it has to travel to your liver to be metabolized, and if you're unlucky, it can set off some clotting enzymes in your liver. But, we've largely moved away from tablet estrogen now, and we use what we call body identical estrogen, which means it goes through the skin, so a patch or a gel. And in those preparations, it doesn't need to go anywhere near your liver, so it is impossible to set off a blood clot. And actually, we know that even people that have had a previous blood clot, they can safely take estrogen through their skin, but most of them have been told, no, sorry, HRT is a complete no-no for you. So again, it's trying to re-educate both women and healthcare professionals about the relative safety of what we now term body identical HRT.
And women with migraines, I've had a lot of people who wouldn't be given HRT because they've got migraines. And of course
actually migraines can be exacerbated at menopause.
Yes, it's a common presenting symptom.
So, sort of they're in just this awful spiral, aren't they, of not being able to get the treatment they need, and actually their migraines getting worse.
Exactly, due to the fluctuating levels of estrogen. Giving estrogen back will actually reduce their risk of migraines. And people worry, I think, from a medical point of view, if you have migraine with aura, that per se will increase your risk perhaps a little of stroke. And then adding an oral estrogen could increase that further.
Yeah.
But actually the good news is that these women with migraine with aura are perfectly safe having the transdermal, as Sarah said earlier. It doesn't affect your clotting risk at all. So migraineurs can safely have HRT, but we would recommend a transdermal through the skin type of estrogen. Yeah. So that's another myth. I think is important to get out there. And of course, people think HRT doesn't help their bones or their heart. It's huge important.
Again, I mean, we sound a lot like a broken record today because we keep talking about education, but that really is what it comes down to. I mean, sort of we have many studies about how much estrogen helps with bone protection, how much, as Sarah said earlier, how much it helps with the heart. But again, it's getting those messages, and hopefully this will help to do that. It's getting those messages out there to people, isn't it? For them to understand that, do you know what, even if you're not having lots of symptoms, you're hopefully going to live a very long life, and you need to be thinking now about how you protect that long-term health, particularly when we think about the figures for osteoporosis, sort of, and bone fracture, etc., etc. It's massive, and the costs, the costs to the individual woman, and also the costs to the NHS are enormous, aren't they?
Huge. 1 in 2 women over 50 could have a fragility fracture. I find that amazing. Amazing. Other questions. Should women over the age of 60 be allowed to start HRT?
That's a good question. It's what we know is we've got this concept of what we call a window of opportunity. Ideally, we want to get HRT into those women for whom it's appropriate, which is most, within the window of opportunity whereby their body is still healthy and they've still got plenty of estrogen receptors which are sensitive. So you really want to start HRT during your perimenopause or within 10 years of your menopause or before you reach 60. And there you will get the absolute maximum benefit with very negligible risks. Once you get beyond that window of opportunity, which usually is women in their 60s, what I say to women is if we use the right type of HRT, then you probably haven't got quite the sensitivity to it, so you'll probably get less benefits, but what's important is the risks don't increase because you're older, because we're using the safest sort of HRT. So rather than in a younger woman you've got massive benefits, very small risks, with an older woman this level just comes down. The risks. But some women, especially those that are the ones that are very prone to the hot sweats and they're going on lifelong, and they sometimes come to us in desperation and say, I haven't slept for 15 years because I sweat and wake up every night, and then they go to the toilet because they've woken up in the night, and they could then fall and break something, and actually you sometimes try, let's try a little bit of this HRT and we'll give you the safest type, and actually it's life-changing, and they say, wow, I can now sleep, and the benefits they're getting to to their bones, and to how they feel and how they function, and the mood improves because they're not so tired. So it can still be life-changing. But again, it's an individual discussion,
individualised choice again, isn't it? Sharing the options. So yes, we can.
And the other really important thing about the older women is actually using vaginal estrogen if they've got the symptoms of vaginal dryness or urinary symptoms or both is very, very safe, and it can be hugely beneficial.
And you can
because that's another myth.
That's another myth. You can't use one. You have to have one or the other.
Exactly.
A whole year of taking vaginal estrogen twice a week is the equivalent of one HRT
tablet, isn't it?
So of course it can be used safely. And 20% of women who are on systemic HRT still have vaginal dryness. So they do need both to control both symptoms. Then that's important. What about women who've had a history of endometriosis? Can they take HRT?
That's a really interesting one, and there was a fascinating talk here not that long ago by an expert in
Chris
that area. He was fantastic. It's really interesting how many women are told they can't. And just as a slight aside from that, so for me, I had a total hysterectomy. both my ovaries, my womb and my cervix, but I did have stage 4 endometriosis.
Right. Yeah.
So when I was prescribed prescribed estrogen, there was no conversation about the protection of body identical progesterone for me for a short time, because obviously you can still have tiny bits of endometrial tissue.
Yeah.
So for women who were in my situation, then they should have some progesterone at least for a couple of years to, you know, kind of to see how their body is going to react. But the endometriosis thing is really interesting. And also fibroids is another... Do you see a lot of women?
They're not allowed it because they've got endometriosis. No, they can have it. There's special considerations you've just alluded to, but still can have it. And fibroids, they've been told, no, because you've got fibroids. Again, that's completely wrong. We may tailor it slightly differently. Perhaps if they're having heavy bleeding, we can use the Mirena coil to control that bleeding. But that's not a contraindication at all, is it? No. What else have they asked? Should women be encouraged? It's a good one. Should women be encouraged to use a lower dose of HRT with time?
What I say to women when they go onto HRT is because primarily the most useful bit of the HRT is the estrogen. That's the kind of the prime thing. Is I say think of it as a ladder.
Yes.
So we tend to put them on near the bottom of the ladder and monitor them and sort of see how they progress, and we climb up the rungs, you know, so one at a time. And some women can progress faster because they need more, and some slower. And then most women, usually in their 50s, sort of reach a plateau point where they're perfectly well controlled and everything's good.
Yes.
And then what you tend to find, because your estrogen receptors do get less sensitive as we get older, that you end up not needing so much. So at some point, maybe in the later 50s, early 60s, you can very gradually start to climb back down that ladder. And the beauty of patches, and particularly estrogen gel, is that the woman has control over how much she uses.
Slowly decreasing it.
And a woman knows her body better than anybody else does, and many women work that out for themselves. And we have some women that come here to this clinic who, you know, are really quite elderly, and they are using maybe just half a dose of gel, a lovely little dose, and it's keeping them absolutely perfect.
And good for their bones.
It's brilliant.
Yeah, no, that's useful to hear that. Is the Mirena on its own HRT?
No, that's another really common myth, isn't it? You know, women have had a Mirena coil put in normally because, well, either for contraceptive purposes or because they were having problems with heavy periods, and they think, oh, hormones, brilliant, maybe I will now feel better. And actually, there is a degree of benefit from it, because actually, if your heavy periods were draining you, then, and you feel better from that point of view, that's great. And progesterone on its own can help with sleep, and in some women, anxiety. But actually, there is no estrogen in a Mirena coil. So the ideal scenario is you have your Mirena coil to give you your progestogen, but then you also take estrogen through your skin. And the combination is a brilliant combination.
Actually, isn't it?
It's nice and simple, isn't it?
It is nice and simple. You've got your if you're perimenopausal, you need contraception. Mirena will cover that. And most women don't really bleed at all, and it's the gold standard at keeping the lining of the womb thin. Actually, it's
and the other thing, because many women, I mean, women of all ages, sort of below 60ish, can use Mirena coils for different reasons, but actually, it's a very common contraception that we use sort of when childbearing has finished. So it's often in sort of 30s and 40s, which can then, of course, often mean that women may have a Mirena coil in their, say, their early 40s or mid 40s, and actually they don't have periods, so they are thinking, well, how am I ever going to know when I'm menopausal? And actually, that is, you know, it's not the easiest scenario to deal with, but I think the important thing is, if you understand that the perimenopause is not just about your periods changing, it's about noticing symptoms that weren't there before, and maybe noticing worsening PMT or worsening changes with the vagina or the waterworks, or sometimes starting to get intermittent bouts of hot sweats or flushes or anxiety and those sorts of things. If things are changing,
the multi-system approach,
even though you haven't got your periods as your sort of barometer, then think, perimenopause.
Yeah.
And that's how doctors should diagnose it, of course,
Yeah.
isn't it? Is a clinical diagnosis,
Yes.
just as you said, all those, and it's the green climacteric scale, which is I find really useful because it just documents all those symptoms you've just said, and you can soon see, a woman's perhaps had a hysterectomy or on the marina who doesn't bleed. Oh yes, these fit in with the perimenopause, and then treatment can be started. One more question about testosterone, actually. We talk about HRT. We tend to talk about estrogen and progesterone, but of course there's another hormone that's important that females produce in the ovaries, testosterone, and we do use that in replacement as well.
I think the biggest myth about testosterone is that it's a male hormone.
Yeah, and women are shocked to hear that it's a female hormone as well. Yeah.
Absolutely,
Yeah.
and also that it's just about libido.
Yeah.
That it, it does so many other things. It helps with bone health, muscle health, cognition, how you feel about yourself, your self-confidence, etc. I think that's a massive myth that we need to get over, and I think it's very much instigated by the media, because it's always referred to as a male hormone, when actually we should be referring to it as a hormone that men and women have.
Yes, it's a tenth of the dose of the men, but it's exactly the same hormone, isn't it? Yeah. So testosterone can also be used, can't it, in HRT?
Again, as you said, Diane, it's, we talk about libido, and it's almost like we sort of need permission to be allowed to say, well, yeah, I'd quite like to have a good libido and I'd quite like to enjoy a good sex life. And actually, we know there's been studies done that show that if men have regular sex, that improves all sorts of other aspects of their health and their cardiovascular health and that sort of thing. And yet, it's almost like an equality thing that actually women aren't allowed that benefit.
How very dare you.
But actually, we know it helps that. There's no doubt about that. But actually, the benefits to mood and energy and concentration, mental focus, physical stamina can also be life-changing for some women, regardless of libido.
Yes.
And so it's
particularly those women in surgical menopause or very early menopause.
Younger people exactly really do benefit from that, and if you haven't got an ovary at all, it's 50% of testosterone is produced by the ovaries. So they do miss that more.
So I think what's important for women to know is that actually HRT is the crucial bit. So what I say is it's a bit like making a cake. Estrogen is like the sponge of the cake. That's the bulk of the cake, and that's what will suit. Most women will be very happy with that bit. Then you put the icing on, which is the progesterone. Depending on your uterus situation, and that can enhance the cake or sometimes spoil it. We want to choose the right one. And then the cherry on top of the cake for some women is testosterone, but you want to start your HRT first and then have another conversation.
Well, on that note, cherry on the top, I think that brings us to a good conclusion. It's a good point to end. Well, thank you very much. I think that's been really insightful, and hopefully we've got rid of a few myths there for people.